Welcome to the start of 4 days of learning, teaching, networking, celebrating, recharging, and just plain fun in magical Orlando. On behalf of the Board of Governors and staff of the National League for Nursing, I'm thrilled to welcome you all to Leading Academic Progression, Advancing the Health of the Nation. As we begin the second decade of the 21st century, this is not the time for business as usual. The demand for the highest quality professional development opportunities for nurse educators is huge because we're being challenged in an extraordinary way. With the release of the IOM's Future of Nursing report, it has become apparent that as nurses, we are called upon to practice to the full extent of our education and training. It is our job to ensure that our graduates achieve the best education and training. So we must be highly competent nurse educators. The NLN Education Summit is an important avenue to those goals. So we're especially pleased to begin this summit with a keynote address by none other than Dr. Donna Shalala, who chaired the committee on the Robert Wood Johnson Foundation Initiative on the Future of Nursing and helped draft the IOM report.
Before we get to Dr. Shalala's much anticipated keynote, there are many people and groups we would like to acknowledge. This year, there are 11 schools here with 10 or more faculty members. We have 500 plus nurse educators with us for the first time. These are called our virgin attendees. You need to be very good to them. And we have participants from 6 countries: Australia, Canada, Japan, Lebanon, South Africa, and from Puerto Rico.
Now it is my great pleasure to introduce my colleagues, the members of the National League for Nursing Board of Governors, and I'm thankful each day for their wisdom during my tenure as League President. Colleagues, please stand as I call your name. President-elect Judith Halstead, Treasurer Mike Newsom, Secretary Joan Fry, Rume Alexander, Julie O'Quinn, Gail Baumlin, Ann Bevere, Carol Boswell, Michelle Cooper, Pamela DeVito Thomas, Linda Howe, Cheryl Killian, Brother Ignatius Perkins, Teresa Schellenberger, Elizabeth Speakman, and in no way least, Jane Sumner.
And of course, our president, Dr. Kathleen Schultz.
Thank you. Next, a heartfelt thank you to our most recent past presidents who exemplify leadership. And if you're present, please stand and remain standing so that we can celebrate your leadership once all names are called. Elaine Taylorini, Tony Bargliotti, Joyce Murray, Eileen Zungalo, Nancy Langston, Sheila Ryan, Jean Watson, Carol Lindemann, Claire Fagan, Patty Hawken, and Sister Rosemary Donnelly, and Rita Dumas, who is deceased.
Of course, we would have a hard time reaching nurse educators across the country without the dedicated presidents of our 24 affiliated constituent leagues, currently serving 29 states. Please stand, colleagues, as your name is called, and please hold your applause until the end. In alphabetical order by state, they are Retha Cabanis from the Alabama League, Karen Saywert from the Arizona League, from California, Tris Haynes, hailing from the Connecticut League, Judy Catalano, Lisa Jordan from the DC Maryland League, From the Indiana League, Karen Harden. From the Iowa League, Barbara Craig. From the Kentucky League, Emily Piercy. Lanetra Jefferson from the Louisiana League. Carol Bosworth from the Massachusetts and Rhode Island League. From the Michigan League, Kathleen Kessler. From the Missouri League, Show Me, Nancy Frederick, and Cassie McCanney from the Nebraska League. From the New Jersey League, Eileen Williamson. From the North Carolina League, Mark Hand. Penny Lynn Rowland from the Ohio League, and Linda Coyle from the Oklahoma League. From the Pennsylvania League, Jane Seahan. Betsy McDowell from the South Carolina League. From the Texas League, Debbie Mercer. Texas would get me if I didn't say it right. Donna Lukic from the West Virginia League, and Terry Cole from the Wisconsin League. And a special thank you to Kelly Bassel, president of the league, representing our host state, the Florida League for Nursing.
And the voice of the nursing community is also heard throughout the land, thanks to those of you who are fellows of the NLN Academy of Nursing Education, those who are certified as academic nurse educators, those who are faculty at Centers of Excellence schools, and those who are our NLN ambassadors. We so appreciate the work that you do. Would you all please stand? Look at that. Wow.
Impressive, very impressive.
Please join us also in acknowledging our NLN subsidiary affiliate colleagues, NLNAC Commission Chair Elizabeth Mahaffey and Executive Director Sharon Tanner. Interim Chair of the NLN Foundation for Nursing Education, Patricia Henton Walker. And from the NLN CNE Commission, Chair Nancy Shart-Hopko. Next, we'd like to salute our colleagues on the Tri-Council for Nursing. Together, we do, as leaders in American nursing, that work that is vital. And we keep the voice of the nursing education community loud and clear. The President, President-elect, and Executive Director of the American Associations of Colleges of Nursing, respectively, Kathleen Potempa, Jane Kirschling, and Polly Bednash. President Karen Daly, Vice President Karen Ballard, and Chief Executive Officer Marla Weston from the American Nurses Association. And from the American Organization of Nurse Executives, President Cheryl Hoying, President-elect Laura Kamamanika, and CEO Pamela Thompson. We salute our Tri-Council colleagues.
We'd also like to recognize these colleague leaders as they stand. Kathy Apple, Chief Executive Officer, and Nancy Spector, Director of Regulatory Innovations of the National Council of State Boards of Nursing. Executive Director Diane Mancino and President Carolyn Hosley of the National Student Nurses Association. Director of the HRSA Division of Nursing, Julie Sikorsky. Karen Morin, President, and Pat Thompson, CEO of Sigma Theta Tau International. CEO Franklin Schaefer of CGFNS International. And President-elect Beth Mancini and Interim Executive Director Jennifer L. Manos of the Society for Simulation in Healthcare. The NLN has a new partnership with the Society to produce simulation, particularly in the area of interprofessional education. The NLN is grateful to the following individuals and organizations for their ongoing generosity to the League and to nursing education. Please stand as your name is called. From the John A. Hartford Foundation, funder of the ACES program, its executive director and treasurer, Corrine Reeder, and program officers Amy Berman and Rachel Watman. Executive Director Darlene Curley and Regine Dunn, Special Projects Manager of the Jonas Center for Nursing Excellence, sponsor of the NLN Jonas Scholars Program. From Laerdal Medical, which is funding numerous initiatives, Executive Chairman Tora Laerdal, Global Vice President of Sales and Marketing, Clive Patrickson, and David Johnson, President, Laerdal Americas. From Johnson & Johnson's Campaign for Nursing's Future, sponsor of the J&J NLN Faculty Leadership and Mentoring Program and the 2012 LEAD Program, Andrea Higgum and Lori Kranick. Sarah Thompson Mishurov, Program Strategy Manager at the Hearst Foundations, which are supporting the national expansion of ACES, and Anthony Battaglia, President and CEO of Pocket Nurse, whose grant to the League has enabled us to expand the NLN Scholarly Writing Retreat. Please join me in a big round of applause. Next and finally, we want to thank this year's Star and Platinum sponsors and the sponsors of both summit-wide items and today's event. Please hold your applause until we have acknowledged all of our sponsors. First, our superb Star sponsor, Laerdal Medical, which in addition to being featured on the back of our Summit tote bag, has again generously sponsored our hotel key card sponsorship. You will not be able to get in your room without them. Thank you to our Laerdal, Clive Patrickson, and David Johnson. And the Nurse Family Partnership, also featured on our tote bag and sponsor of the 2011 CEO Summit Address. Thank you, Tom Jenkins, President and Chief Executive Officer. Next, our generous platinum sponsors. Chamberlain College of Nursing is supporting the opening reception you'll all enjoy at the close of this session. Thank you, William Richard Cowling III, Vice President of Academic Affairs at Chamberlain College of Nursing. Thank you, Dean Marion Broom and Indiana University School of Nursing for sponsoring the program book with the back cover. The Summit Program Guide also proudly sports inside back cover art, thanks to Dean Eileen Zungalo and Duquesne. And new this year, the American Nurses Association, represented here for the very first time by Francine Bennett, has sponsored art on an inside tab. Finally, thanks to the 17 current Centers of Excellence in Nursing Education for supporting today's keynote address. Brookdale Community College, Christ Hospital School of Nursing, Community College of Philadelphia, Duquesne University, East Carolina University, Excelsior College, Hunter Bellevue School of Nursing, Indiana University School of Nursing, Johns Hopkins University, Regis College, St. Xavier University, Trinitas School of Nursing, University of North Carolina at Greensboro, University of Oklahoma College of Nursing, University of South Dakota, UPMC, Shadyside School of Nursing, and Villanova University. Please join us in acknowledging these sponsors for their generosity and support.
And finally, words can hardly express the gratitude due to NLN's creative and dedicated staff. As always, they've worked and continue to work and create, not only to ensure an outstanding summit for all of us, but to keep NLN the best and the brightest organization for nursing education. They are a magnificent team. Please join me in thanking them. And now, it is my distinct privilege to introduce our keynote speaker, whose leadership in the arena of healthcare policy and education contributed so greatly to the much heralded and indispensable IOM report, The Future of Nursing, Leading Change, Advancing Health. Donna E. Shalala has a long record of helping to shape healthcare policy that benefits all Americans. President of the University of Miami since 2001, Dr. Shalala is an accomplished scholar, teacher, and administrator with many years of professional and life experiences. One of the country's first Peace Corps volunteers, she served in Iran from 1962 to 1964. She earned her PhD from the Maxwell School of Citizenship and Public Affairs at Syracuse University. In addition to tenured professorships at Columbia University, the City University of New York, and the University of Wisconsin, Dr. Shalala served as president of Hunter College from 1980 to 1987, and as chancellor of the University of Wisconsin from 1987 to 1993. In 1993, President Clinton appointed her U.S. Secretary of Health and Human Services, where she served for 8 years, becoming the longest-serving HHS secretary in U.S. history. At the end of her tenure, the Washington Post described her as one of the most successful government managers of modern times. Dr. Shalala has more than 4 dozen honorary degrees and a host of other honors, including the 1992 National Public Service Award, the 1994 Glamour Magazine Women of the Year Award, and in 1992, also Business Week named her one of the top 5 managers in higher education. In 2005, she was named one of America's best leaders by U.S. News and World Report. In 2008, President Bush presented her with the Presidential Medal of Freedom, the nation's highest civilian award. And in 2010, she received the Nelson Mandela Award for Human and Health Rights, which recognizes individuals for outstanding dedication to improving the health and life chances of disadvantaged populations in South America and internationally. She has been elected to the Council on Foreign Relations, the National Academy of Nursing Education, the National Academy of Public Administration, the American Academy of Arts and Sciences, the American Philosophical Society, the National Academy of Social Insurance, the American Academy of Political and Social Science, and the Institute of Medicine of the National Academy of Sciences. Please join me in welcoming Dr. Donna Shalala, a woman who lives her mission to deliver the NLN Education Summit keynote address.
Thank you very much, Kathleen. Thanks very much, Kathleen. President Schultz, my good friend Beverly Malone, your CEO, who I've known probably for 20 years now. I'm delighted to be here. Actually, my resume is longer than my speech. I remember when it was shorter. And that, in some ways, is the point. 3 million strong American nurses, and it's time that you all acted like it. I came today to talk a little about the Institute of Medicine report, and I have to acknowledge the critical role of the Robert Wood Johnson Foundation, and Sue Hassmiller in particular, for not only funding, but help to lead the effort to produce the report. Every once in a while, a report comes out of the National Academy of Sciences that catches a wave and makes a difference. And it was really the leadership of the National Academy of Sciences, of the Institute of Medicine in particular, and the Robert Wood Johnson Foundation who came together because they believed, and convinced me of the same, that this was the time for nursing to get more than a boost, to get the opportunity to lead healthcare reform in this country. And in fact, the context for the IOM report is healthcare reform. That report was so significant, actually, the day it came out, it crashed the computers at the Institute of Medicine. And it's the all-time bestseller in the history of the Institute of Medicine and the National Academy of Sciences, which meant that everybody in this room either downloaded it or bought a copy. We're living in what I believe will be the golden age of nursing, because we're living during a period in which we're going to transform the healthcare system in this country. 38 million Americans will, in 2014, have the opportunity to get coverage that they haven't had before. We will begin to move towards eliminating the fee-for-service system. We'll find new ways to contain costs and new ways to ensure that the quality of healthcare improves in a seamless way. Those are the great challenges of healthcare reform. But to do it will require all of the health force in this country, and in particular will require new roles for nursing in leadership positions, in particular in thoughtful teams with other healthcare leaders, including doctors and other healthcare professionals. Those teams will have to reshape the healthcare system in every community in our country. The outline for that reform is, of course, the 2010 Affordable Care Act, and the history of this country moving towards universal health care is a history filled with very painful periods in which politicians tried to transform the healthcare system without the resources or the political will on behalf of Congress. Beginning with Franklin Roosevelt, when he began by introducing Social Security, he very much wanted to do healthcare at the same time. A very conservative cabinet stopped him, and for the first time, the American Medical Association raised their heads and described it as socialized medicine. Any entry of the United States government into broader coverage, any movement from the private sector to the public sector for coverage, even though it was very clear at the time that senior citizens did not have serious access to the healthcare system. And so Franklin Roosevelt simply went ahead and took the Social Security victory, which of course was one of those critical points in American social history. And it was left to his vice president, Harry Truman, to try to get healthcare reform. Harry Truman writes in his own autobiography that it was the great failure of his career to not being able to convince the American Medical Association and the Congress to put a universal health care system in place for 65 million Americans. It took Lyndon Johnson, the master of the Senate, the man who could cut any deal for any purpose, to convince the Congress of the United States to pass Medicare. And at the same time, a member of Congress from the South tacked on something called Medicaid, convinced that Medicaid would be a proxy for poverty, knowing as a Southerner that that would put millions and millions and eventually billions of dollars into the South. The Medicaid program attached to the Medicare program began the giant steps towards universal health care that we know so much about today. And it really, if you look at the South today, Medicaid is in fact the largest employer in a number of southern states. So powerful are the millions of dollars that flow from the federal government to state governments. And most of the southern states, all of them as a matter of fact, get more than 50% of their income from Medicaid from the federal government. And of course, with the introduction of healthcare reform, we'll get much more. And so the point is that we've taken periodically giant steps in healthcare reform. In fact, when Lyndon Johnson signed the bill, he went off to Independence, Missouri. And that, of course, was where Harry Truman and his wife Bess were living, and he signed the bill there, and he gave the first cards, the first Medicare cards, to Harry and Bess Truman. As Johnson was walking out, a young reporter from the New York Times came up to him and said, "Thank you on behalf of my mother." And Johnson said to the young man, "No, you should thank me on behalf of yourself." The reporter at the time thought that Johnson was simply explaining that someday he would need Medicare, and in fact that reporter, Max Frankel, who became editor of the Times, is currently on Medicare. But that wasn't the point that Johnson was making. Johnson was making a very important point. His point was that Medicare would become, and Social Security, would become middle class, middle-age subsidies, that no American family in the future would be able to send their children to college or to buy a home if Medicare and Social Security were not in place. That political message is important for us today because as the Congress and their special committee begin to debate how they're going to reshape the healthcare system and how they're going to pull some resources out of Medicare in particular, and perhaps shift increasing costs for Medicaid onto the governors, one must understand that the politics of all of this is not simply the politics of senior citizens, but the politics of all of us. That all of us have changed our lifestyles because of Medicare and Social Security in particular. And if you would think of the elderly members of your family, if you had to deduct from your paychecks the equivalent of what they get in Social Security, or if you had to go into the marketplace and buy a Medicare plan for everyone in your family who was over 65, it would dramatically change the quality of your lives. And if it would change our lives, imagine the millions of Americans for whom these programs are at the core of the quality of life that they currently have, no matter what their ages are. And so we cannot see these programs as simply another governmental program that can be easily chopped up and divided up and shifted to the private sector. For the senior citizens in this country in particular, and for the new generation of workers who do not have health insurance as part of their employer benefits, the new programs that will take place in 2014 and the old programs that were put in place in the 1930s and the 1960s are critical parts of the economy of our country, as well as critical parts of the lifestyle of every American. And I start with that context because it is that context in which nursing plays a particularly important role. We need to reshape the healthcare system. We need to move away from fee-for-service, which has been devastating in terms of the growth of healthcare costs in this country. We need to improve the seamlessness of the experience of our patients from the point at which they enter the healthcare system, even before, in terms of prevention, and other kinds of healthcare programs, to patient safety, to chronic care management, to end-of-life management. The entire healthcare system in the United States needs to be reshaped, and that is the context in which the IOM report was written. The IOM report rests directly on the conversation that's going on in this country and has been going on since Franklin Roosevelt about who should have health care, how they should have access to health care, what kind of health care they ought to pay for, what kind ought to be provided, and about the quality of the health care experience and the safety of the health care system. Nurses cannot be left out of that discussion. As nurse educators, you know a great deal about the patient experience, and much of nursing's research has been patient-centered. Much of nursing identification with the healthcare system has been patient-centered. And that's exactly the world that we're going to move to. It has to be a patient-centered system. It cannot be a system that's built for the doctors or the nurses. It has to be built around patient needs. And what's good for the patient is good for the healthcare system and ought to be good for all of us in this country. And so if you look at the recommendations of the IOM report, practice to the full extent of training is a recognition that nurses are better trained than they're able to practice. And it's time in this country that we broke down the scope of practice regulations state by state and allowed nurses to practice all the way up to their training. And that was the first recommendation of the IOM report. Now, I started by saying 3 million strong. The fact is that we outnumber all the other healthcare providers in this country, in particular, those that play the political role to restrict practice. And nursing has to get its muscle on, state by state, and start breaking down some of those scope of practice rules. We've got to be part of the discussion in the states about making certain that no part of the healthcare profession is limited in their training from practicing what they've been trained for. Licensing and practice rules vary by states, and it has nothing to do with the ideology of the people in the states. The most liberal states in terms of scope of practice are the most conservative states in terms of their political practices. And so this means that it's the peculiarities of the history of the role of the medical practice in that state, the way the politics has played itself out. And nursing is going to have to step up and take on all of the politics in their states to try to expand the scope of practice. Now, the federal government can help. And one of the more interesting parts in the small print of the report is it calls on the Federal Trade Commission and the Attorney General of the United States to take on these issues because of the discrimination that's taking place from state to state. And it also calls on the federal government to take a look at the authorities that they have within the Medicare rules to see if they can simultaneously expand the scope of practice. We've seen in the VA what happens when you expand the scope of practice. We've seen in some of the most conservative states in the United States what happens when you expand the scope of practice and allow nurses to practice up to their training. This is not just an issue for nursing. It's an issue for the rest of the healthcare system, where they can appropriately play roles that will improve the quality of the healthcare system. We also know that we have to invest more in education. And the report was very careful in discussing education. We called for 80% of the nurses in the country to have their bachelor's degrees by 2020. We were very gentle about not doing what some parts of the nursing profession would have liked us to do, and that is dismiss the LPNs and the RNs. What we said was that there should be seamless transitions and opportunities for people who entered at the LPN or the RN level to get to a bachelor's degree in nursing. And I want you to know that is one of the places where I actually personally played a role. Because in my family, which is a working class family in Cleveland, Ohio, a number of my cousins are either LPNs or RNs. And I wasn't about to let the elitist piece of nursing to discriminate against people that are entering where they have to enter, rather than providing opportunities for people. And I think it's very important for nurse educators to be respectful both of the diversity that comes in the LPN and the RN levels, as well as providing opportunities in our 4-year programs for people to move on and to get more training. It's the ongoing training that will ensure nurses' leadership, not simply where people enter in the system. But the most important recommendations are about leadership and about full partners in the delivery of care, and about nursing being able to be at the table and to be an equal partner. There are some parts of the health professions that didn't like the word equal partner, didn't like the word partner, let alone equal. But it was very clear on the panel, and only half of which were actually experts in nursing, and I was not one of them. It was very clear on the panel that reshaping the healthcare system requires a partnership. Whether it's in an acute care setting or whether it's in a community setting or in all the other places where nurses have important roles, it has to be a partnership. And people have to see their roles and their experiences and bring them to the table to reshape this healthcare system. We cannot do it with just a narrow part of the health profession making the decisions. We learned that long ago, and it's time that we join together at the table with all the other health professionals and reshape this system for the patient, for improving the quality of healthcare and the safety of healthcare. That, in fact, from my point of view, that leadership recommendation, along with all of the other recommendations, but the leadership recommendation is the real one for this, for all of you. It requires a level of aggressiveness and shrewdness and political savvy over the next 5 years, because that will be the critical period in which the healthcare system is reshaped. Whether you're talking about accountable care organizations, whether we're moving towards a different kind of HMO, whether we're going to go into something that makes me very uncomfortable, the high deductible plans, whatever they are, we have to make sure that we protect the patient and that the patient has access to the highest quality care no matter where they live in this country. And in my judgment, that requires nurses to be front and center and to bring their experience to bear at the table. It also requires that we make extraordinary investments in the education of nursing. In the PhD programs, where a number of the foundations, I think in particular the role of the Jonas Foundation in funding PhD programs across this country, we need more investment in future faculty members. We need more investment in the cost of nursing education. And we need that from our presidents of our universities, as well as from the foundations in this country and from the government. Unless we have the faculty in the future, we are not going to be able to meet the need in this country. But it's not just getting people their degrees, it's the ongoing education of those students. We know that residency programs make a difference in terms of reducing the number of people that drop out of nursing and increasing patient safety. We know that continuing education makes a difference as people transfer to different parts of the healthcare system. We know that that continuing education requires very skilled people on our nursing faculties, both the tenure track faculty as well as our clinical faculty. Those investments over the next 5 years will be the most critical investments, as so many of us get close to retirement and have to step down from our current positions. So focusing on investments in future faculty, I'm delighted that so many PhD students are here today. Focusing on being able to give people an opportunity to move from one degree to another. Focusing on giving nurses the opportunity to be part of the major decision-making that's going to take place in this country will improve the quality of healthcare in this country, will improve the scope of healthcare in this country, and more importantly, will make us finally reach the dream of universal healthcare. Thank you very much. Thank you. Thank you, thank you. Thank you, thank you. Thank you, thank you. Now, I actually give short speeches because I like to talk to the audience. So we've got a couple of microphones. The rules are usually that you introduce yourself and the place where you are currently working. Questions? I think you have to walk up to the microphones. I can barely see.
Milwaukee, Wisconsin.
Hi.
Hi, I was on the executive committee the other day, and they mentioned there's changes in Medicare, possibly shifting to hospitals and providers to avoid any encumbrance on the patient. Comments about that?
Yeah, I'm not quite sure. Most of us have not seen the real details of the president's recommendations. There's no question, though, that they're going to take some shots at hospitals and try to reduce some of the costs. The big savings the president has identified, in addition to raising taxes on people that make more than $1 million, not an issue that will affect most of us, is going to be in Medicare Advantage plans. And that is, all the evidence is that we've been overpaying for those plans. We overpaid for a particular reason. We were trying to coax good HMOs back into the system because most of us believe that coordinated care is absolutely critical to improving health care. And so I think most of the cuts are going to be there, but the hospitals and the doctors do expect to get cuts as part of this. There will be some bundled payments, some attempts to do some bundling so that the hospitals get a certain amount of money risk adjusted for every patient. That will put some pressure on the hospitals to make sure there aren't readmissions, which Medicare has also already set up some rules on, but also that the patient is well taken care of before they leave the hospital as efficiently and safely as possible. That means the hospital will do the allocation in terms of payment, and nursing will have to be front and center to make sure they get their fair share. Yes?
My name is Teresa Delhood. I teach at Bryan LGH College of Health Sciences in Lincoln, Nebraska. And I have been in nursing education for 10 years now, and I'm brand new in my role as Dean of Nursing in the last 2 months. And I had a meeting with the Chief Nursing Officer at one of the major medical centers that we do our clinicals with to kind of talk to them about this transition and the 80-20 requirement and what her thoughts were about how we could help facilitate getting more BSN prepared nurses in the medical center. And her comment to me was, well, that's nice, but she was all for having more education, but really didn't see where the benefit necessarily was. How can I be an advocate with those leaders to try and get this discussion and get them to buy into this?
Wow. I just told my hospital they had to do it. I think the evidence is pretty clear that we're going to need better trained people in the healthcare system of the future, and we just have to make that case. And I think that may not be just the person you need to talk to. I think the nurse educators in your community may have to get together and go see the CEO of the hospital and make your case with the nurse leader there at the same time. But if you call Linda Burns Bolton, who was the chief nursing officer and was my vice chair at Cedars-Sinai, and tell her your story, she'll call her. And I would not mess with Linda Burns.
I want to keep my job.
No, I just wouldn't mess with Linda Burns Bolton. But I would go back. I would not give up on that issue because a number of healthcare systems around the country have already adopted this, are starting to move, are starting to say that their new nurses The new people that they hire must have bachelor's degrees and are beginning to set up transition programs for current RNs so that they can get their bachelor's degrees. And one of the things that you have to offer is an opportunity for people who are currently in the system, and it's got to be part of probably a grand deal. There are a number of people here. This is a new dean. There are a number of deans here who aren't so old but have had experience with this, so I think we could use a little mentoring and coaching over here. All right.
Well, I'd like to comment to what just was said. I'm Diane Breckenridge. I'm from Philadelphia. I am associate professor at LaSalle University and the nursing research director at Abington Memorial Hospital. And I think it's commendable of what you are doing as a new dean and going to the CNO of the hospital. And my recommendation, and I think others that have been in this type of situation quite a few years back, would be pretty much what you just said, Dr. Shalala, and that is...
See, I'm not FAAN for nothing.
All right. And that is going forward in relation to Magnet. And if a hospital wants to have a center of excellence in nursing, they need to have their nurses at the higher skill set.
Right.
Of research and evidence-based practice. And I always call Magnet in healthcare being one of our best friends.
Great. Okay, thank you.
Hi. Thanks very much for your remarks. They are always such a pleasure to listen to. My name is Eileen Zungalo, and I'm the Dean of Nursing at Duquesne University in Pittsburgh.
Great.
And I have two observations that I would like to share about the report. The first of those is in relationship to scope of practice. I'm afraid that many people, when they hear that phrase, think about the advanced practice nurse. Whereas I believe that the scope of practice for all nurses needs to be evaluated, and I don't think that that's being addressed the way it should be.
That's a very good point, yeah.
The other point that I have to make is that I'm very concerned and disappointed that the report did not address the preparation of faculty more. In looking at the preparation that is called for, I certainly recognize that having more PhDs in nursing is wonderful to advance the science. But frankly, people who have PhDs in nursing do not want to teach entry-level students. So they really do not help in improving the workforce or advancing the kind of workforce that I think we want in nursing. So I wish you had indicated in the report that preparation for the faculty role entails knowing something about education.
But I thought we did address the DNP. I thought we did, we certainly had long conversations about it. And I thought we did address the DNP. We certainly didn't cover everything in the report. And it was not a report just about nursing education. In fact, there have been plenty of other reports on that subject in particular. It was really a report on healthcare reform and the role of nursing, but I accept the criticism that we didn't do enough on that. And one of the things we did recommend, though, is that nursing schools include people with other degrees, public health degrees, and broaden their faculties, as well as, you know, I'm a big fan of the Doctor of Nursing Practice degree that we're putting out around the country. I think that gives us an opportunity to get a generation of people, including some of the programs have research tracks, who have had real experience, extensive experience in the field.
Thanks.
Okay. Down here? Yes.
I'm Betsy Frank from Indiana State University, and I'd like to speak from the patient perspective just a moment. How can we as nurses be in the forefront of getting rid of, I think if we changed paperwork alone, we could save billions of dollars. As an example, I applied for Medicare. I got a letter saying, you applied, we'll do something about it. Then I got a letter that says, you've been approved, but if you'd like to appeal, there were 3 pamphlets about appealing. Then I got my card. My husband, who's on Medicare, every single benefit statement comes with, if you'd like to appeal, we could. Why are we doing this?
Well,
how can nurses
when you
promote efficiency?
Well, when you applied for Medicare, you clearly didn't check the box that said you wanted everything electronically.
No, they didn't. There wasn't an option.
Oh, yeah, there is an option.
I looked.
There is an option. Part of it is generational. Within 10 years, this stuff will all be online and relatively easy to manage. And as we're making the transformation, the IT transformation in the healthcare system in general, we'll start saving paper. A lot of that material is pre-tested for the age group with focus groups and other kinds of things. But we're within 10 years of doing this all online as people get more comfortable doing these things online. I did mine all online. Yep. Yes.
Patricia Underwood. I'm the Executive Associate Dean at Case Western Reserve University. And thank you so much for your eloquent challenge to all of us in terms of leadership for the future. You spoke about increasing the number of doctorates, and you spoke about the PhD as being faculty. And I do agree with Dean Zungalo's comments that we as a profession have to begin to grapple with how we are preparing our faculty. And it's not just at the PhD. Could you speak a little bit about the PhD preparation as nurse scientists? Because not all PhD programs, in fact, have that preparation.
Yeah, I mean, I see the PhD as a research degree. It's obviously a teaching degree for faculty as well. My own view in higher education after years of running universities is that we need to mix the appointments more. And we need to do it in terms of salary and other things as well, that universities are so rigid about ways in which you become a faculty member. And while nursing has some flexibility, we still have accrediting rules that require a certain number of PhDs research degrees, that may have very little to do with the preparation. And most of us aren't gutsy enough to stand up and say that. That's true in other professions as well as in higher education in general, that we've gotten ourselves locked into in our accreditation processes of requiring schools, departments to have a certain number of PhDs to get their accreditation, when what we need is skill levels and teaching levels and an ability to mix people a little bit, much more than we're now able to do. And the problem is nursing schools, professional schools have a particular problem because they're sitting in the middle of universities often that are dominated by traditional PhDs who set standards through their faculty senates for everyone, as if every program was precisely the same, and it's very complicated. You have to watch it very carefully. Faculty senates in general are dominated by the arts and sciences, for example, who have a whole different sets of standards, and the professional schools come walking in and they don't quite understand either the substance or the preparation. And nurse scientists in particular, we want more because we want nursing to play a significant role. I signed the legislation for the National Institute of Nursing Research. I mean, we want more nurses to have central roles in healthcare research. So we need PhDs that prepare nurse scientists. We need people in health services research too, as well. So there are different preparations for different folks, and the deans are forced to try to figure out what the mix they need to prepare people at the highest level they possibly can. It's not easy to get people into nurse scientist preparation programs. You have to support them. People have lots of options, and in this country at least, the best programs require total support to recruit the best students. This is not a part-time effort. So it's a challenge, but I think that the rigidity of higher education, the role of tenure, has restricted us from being as flexible as we need to be, particularly in the professions. Whether it's business or nursing or medicine, we're almost hamstrung. Thank you.
Dr. Shalala, it's an honor to be able to address you. My name is Catherine Monetti, and I am a Robert Wood Johnson Foundation scholar studying for my PhD at Rutgers College of Nursing. I may be an outlier in the sense that I have been a baccalaureate RN for 30 years, and I have been teaching for a full 20 years with my master's degree. So I have extensive teaching experience and will be advancing my education, my career, by becoming a nurse scientist with a lot of teaching experience. And I do
If you stop right there, you'd be offered a job in about 5 minutes.
Yes, exactly. So I do hope and intend to continue teaching entry-level students. And I am being trained to be a nurse scientist. Now, my question for you is this. I'm very much in favor of the concept of universal health insurance. I wonder about its implementation, and also enamored of the passage of the Affordable Care Act. From the patient's perspective, the public's perspective, I wonder about current opposition, namely the alleged lack of constitutionality of mandating the payment of insurance premiums.
Well, obviously the mandate's important, though Massachusetts did it without a mandate. Oregon, when they introduced universal health care, they ran out of money because they introduced it without a mandate, and people rushed to get coverage. I think the mandate is important. The Supreme Court will make that decision, so it's out of our hands. The process is really quite simple. The states are going to organize markets. They're going to bid out to the current major health care providers. People are going to have some choices. Those choices are going to look very much like the current private health insurance, probably the best part of it, the current private health insurance. It's going to be mostly to keep costs down, some kind of a comprehensive HMO, probably somewhat restricted. There will be opportunities for high deductible programs, which may be of interest to parents who have 30-year-olds that don't have health insurance, that are pretty healthy. But the products will look very much like the current health insurance market. The only difference will be, depending on your income, the federal government will subsidize some of those products for people that are certainly people that are under twice the poverty line, for example. So there will be some federal subsidies to help people pay for it. But the products themselves will look like the current health insurance market. I make that point because this is reform only to a certain extent. This reform is about coverage for the most part. While the federal government is going to be putting some pressure on to save some money in Medicare, the Affordable Care Act is mostly about coverage. It's about 38 million people that are going to get some choices from markets organized in their states of private health insurance that's close to being affordable. Now, this is also a group of people that work. These are working Americans. The people that don't have health insurance in the United States are not on welfare. You can get Medicaid if you're on welfare. These are working Americans. They tend to be low-income Americans. They've been either paying out of pocket or using free clinics up until now, or emergency rooms, the worst part of the system to enter in from a cost point of view, not from a quality of health care point of view. I happen to think emergency rooms in this country are pretty good, but it's a very expensive place to enter the health care. And so they're going to have to buy health insurance, and they're going to be given lots of choices, and the subsidies will depend on their income. And so it's a pretty straightforward. Some states already have these without the subsidies, and they've had very little take-up. The mandate's important, but I think very large numbers of Americans are going to try to figure out some way to get into the system because they want coverage for themselves and for their families. Half of that 38 million, a little less than half, will be on Medicaid. And those Medicaid programs will probably be HMOs. But again, the subsidies will enter in. There'll be some co-payments and some subsidies to make them affordable. And it's tricky in terms of affordability. I teach health policy, and one of the things I do is I ask everybody, I ask the guy that drove me here, what their health insurance situation is. So I learn a lot about the healthcare system. And my manicurist, for example, her employer offers health insurance, but she'd have to pay, her kids are on the children's health insurance programs, the state programs in the state where she lives, and she could buy health insurance for herself. She's a single mom for $50 a month. That's not a lot of money. But for her, that's her entire discretionary money. That's what she has to take her kids out. So she does not see even the insurance that her employer offers as affordable. Well, she's a burden on the healthcare system if she goes into the healthcare system with an acute illness without insurance, because we can't spread her risk over a lot of people. I was in Detroit during the debate on the Affordable Care Act, and they sent me to talk to the small businesses, and someone from a small business stood up, actually it was a room this big, and said, you know, we don't want the government interfering, you'll just add costs to what we do. And besides, the woman said, everybody in my small business has health insurance. And I said, that's terrific, you're a poster child. She said, no, I don't provide the health insurance. They're all spouses of people that work in the auto industry. That's the problem. My university is paying for spouses who work in businesses in Miami that don't provide health insurance or make it too expensive. And frankly, all of your institutions are doing the same thing. Somehow, we've got to spread the risk and everybody's got to pay their fair share. But it's very tricky. Particularly low-income workers, the elderly, are very price sensitive. Thank you. Yes.
Hi, I'm Mary Beth Gay, and I'm the director of an associate degree program in Rochester, Minnesota. And hi, Elaine. I have, I guess, a question and a comment. I appreciate and I fully endorse the continued and lifelong education. We have very good access to BSN completion programs in our area. And we encourage our students continue education on their first day. My concern is the employers who are saying they must have a baccalaureate degree before they start. Our particular primary employer is allowing 6 years from the date of employment.
Right.
And I think that's very reasonable.
Yeah, in fact, the report recommends 5 years from the date of employment to get a BS.
But with that, I also don't see industry showing any value for that baccalaureate degree, because the associate degree can be hired, the baccalaureate degree can be hired with maybe a 50-cent difference, and yet they say we value this. But in our evaluations, I hear, we don't see a whole lot of difference.
Well,
and one more comment, and then, you know, so I think that's a mixed message for the student. And then what they're doing is saying, in the completion program, which is the fastest route? And I see a huge variance in completion programs, and I'm not sure there's consistency in the quality of that education. But they're looking for a fast track.
Right. The average student who does an RN takes the average student that does an RN takes 3.5 years now because of all the prerequisites. And so it seems logical. And to get programs that fit, they're working, many of the students who get their RNs are working and want to complete that higher degree. And schools are going to have to adjust to that group and adjust to that period of time. But the fact is that there are community colleges in this country, including in my own town of Miami-Dade, who are going to go to a 4-year degree. Their RNs are taking so long because of the prerequisites that they have to take that it makes no sense, and they're going to find a way to make sure that they can do 4-year degrees and work if necessary to get those degrees. But you're right, there's an unevenness in the completion programs, and that's the challenge for everyone. One of the reasons there's an unevenness, though, in the programs is because people are at different points in their lives in terms of how they can finish up and finish their bachelor's degrees. And so there is a market response to that, and it's not necessarily a traditional institution. And we have accreditation challenges to make sure that the quality of those completion programs are just as high. But there's no question that there's an unevenness, but that unevenness is because people have been designing market responses. Yes?
Thank you.
Thank you very much, Dr. Shalala, for your work. I'm Karen Kowalski, and I teach part-time at Texas Tech in the summer in the DMP program in leadership. My day job is that I'm the president and CEO of the Colorado Center for Nursing Excellence, and we are the co-lead along with the Colorado Hospital Association.
You fly from Colorado to Texas Tech?
I know, it's pretty confusing.
Yeah.
We're the co-lead with the Hospital Association in the Colorado Action Coalition. I was attracted to the efforts of AARP and RWJ in moving the recommendations forward because my career has been very nurse-centric. And the emphasis now in these efforts is how do we join together with non-nursing organizations to move the recommendations forward. I was wondering if you had some recommendations or some thoughts about strategies for connecting, if you will, to these non-nursing groups.
Yeah, I'm a big believer in building these coalitions. These non-nursing coalitions, and mostly you need to approach them, whether it's the healthcare industry in your state, or simply other professional organizations, chambers of commerce, whoever you can find. And I would simply make a list of the most powerful interest groups in the state and go approach them, because they have a self-interest in this working. Because it has to, but the argument has to be, this is about quality. You'll notice that you'll read the whole report and you'll not see any indication that we think that introducing nursing into a stronger leadership role will save money in the healthcare system. And you can't imply that. This is about the quality of healthcare, about access to healthcare, and about using people up to their training. We went through line by line to make sure we didn't send any of the wrong signals. And that's how you build the coalition. Yes?
My name is Suzanne Sutton.
Particularly in the West, where access to entry level and primary care is really going to depend very much on the nursing profession. Yeah.
I'm Suzanne Sutton. I'm a doctoral student, PhD student at the Medical University of South Carolina in Charleston, and I'm an instructor at USC Upstate Mary Black School of Nursing. My question is, we want to produce nurse scientists, and we want to produce nurse educators who are effective educators. However, there's little to no funding available for PhD students who want to do their dissertation research in nursing education outcomes. How can we change that?
No. Well, you're not going to get it out of the government.
Well, we're not going to get it out of the Nursing Institute of Research, the NLN.
Well, no, they're not going to do it either. We've got to find private foundations that are willing to pay for it. And that's why Robert Wood Johnson has organized some private foundations, the Jonas Foundation. Where's Darlene?
Where's Darlene?
So, somewhere out here. find Darlene and the Jonas Foundation people, because they're very interested in broadening the coalition of private foundations to fund PhD programs. Look, there aren't a lot of PhD programs in this country that are fully funded other than the pure science PhD programs. I mean, if you want to go get a PhD in political science the way I did, there's not a lot of funding for it anymore. And so we have to find creative ways, hopefully with some investment out of our local communities and our local community foundations, to help PhD students to be able to get these degrees. And sometimes it's a combination of teaching opportunities as well as other kinds of support that schools of nursing are going to have to put together. They've always had to do it. Now there's an imperative because of what's going to happen in terms of nursing faculty retiring. Yes.
Remember, I'm from South Carolina.
Yeah.
There is no money for school. None.
Hi, I'm Sue Ferneris. I'm a associate professor at St. Catherine University in St. Paul, Minnesota.
Right. I know St. Catherine.
My question might be somewhat simplistic. Wondering if you can comment on strategies around how we as nurses can help move nursing service at the bedside as its own line item in the healthcare bill that the patient gets. Some of the payment mechanisms out there right now are taking money away if nurses don't prevent infection.
Yeah.
So if we have outcomes that show that we do make a difference, why can't we be paid for the prevention of those outcomes?
It's not a simplistic question. It's actually a very complicated question. The short answer is that we're moving away from that kind of fee-for-service identification. That was a long-time campaign by the nursing profession to try to get direct reimbursement, direct identification, even in bundled payments. And I think that we're moving in a different direction. And that's why you have to be at the table in leadership positions, in power positions, so that when the allocations take place, when the decisions about who gets paid what, when everybody looks at the market and figures out what it'll cost to have people at different points in the healthcare system, you've got to be at the table, because we're moving in exactly the opposite direction. Yes.
Thank you, Dr. Shalia. We have time for 2 more questions, and here they are.
Okay.
Hi, I'm Pat Yoder-Wise from Texas Tech University Health Sciences Center in Lubbock and Texas Women's University Houston in Houston. My question really takes you to a different place, and that is, what advice from your excellent career in leadership would you provide to us in nursing in terms of our own leadership development?
You know, most people stand up here and said, well, I had 12 mentors and they pulled me along. I didn't. I was just wide awake. And, you know, in some ways, it's like the great running backs at Texas Tech. That is, they're very patient. They wait to see the openings and then they run through. And in some ways, you need sharp elbows to get to the top. And in other ways, you need just a good sense of humor. People have to deal with you. Someone said to me the other day, well, you never suffered any discrimination. I said, yeah, all the way up and down my career until I got to the top. Once I got to the top, they had to deal with me because I was powerful. They couldn't look the other way any longer. So that's why my initial point was there are 3 million nurses in this country. And another football story. When the kid gets to, the great coaches in this country, when the kid runs into the end zone with the football, they say, hand the football to the referee and act like you've been there before. That's what, in many ways, that's what nursing has to do. You have to act like you're powerful, and then you have to elbow your way into the table. And I'm not talking about union organizing as such. I'm talking about nursing using its strength in the same way medicine and other professions do. Frankly, you've got to contribute to campaigns. You get access. The system is set up in the way. I once had a kid who was writing an essay on, the question was very simple. If you had to do one thing to reform the healthcare system, what would you do? And the kid that got the A+, his answer was quite simple. He said campaign finance reform. Well, we're never going to get campaign finance reform. So what we have to do is we have to play the political game. The political game means that nurses have to organize in their states. They have to be a political force, and that's not just marching on state capitals. That's contributing to campaigns, getting in the room when they're having public hearings, getting in the room when they're having open meetings, and making the point over and over again about access, about reimbursement, and about all of the issues that you care about. It also means that we have to take advantage of the way hospitals are reorganizing themselves, and we have to have a new generation of CNOs that get it. My CNO is also the chief operating officer of the hospital. He gets it. He's a nurse. He gets it. And so we have to elbow our way into power the same way every other group elbowed their way into power. They contributed to campaigns. They showed up for the public hearings. They showed up for the meetings in the local community. They went and talked to groups of people. I never see nurse leaders talking to the local Lions clubs. I rarely see them at community service organizations, talking about the role of nursing, talking about the importance of nursing, talking about legislation that's before the state legislature. And so it's pretty old-fashioned, what we need to do in the future. And it's not in Washington. It's very much going to be in state capitals. And the annual Nurses' Day in state capitals is just fine, but you're going to have personal relationships with your local legislators. They're going to have to know you, know your issues, and see you more often than they see the doctors. Now, that doesn't mean if they're flat on their back in a gurney that you're going to have a conversation with them about legislation. Yes, please.
I'm Amber Veer. I'm from the University of Connecticut, and thank you for your remarks. Thank you also for your sensitivity to extra and different disciplines on the faculty of the School of Nursing. Our university will be recognized on Friday for a Center of Excellence, but in that process, we hired physicians, English and rhetoric, PhD prepared persons, statisticians, and the richness that they brought to our teaching and our pedagogy were phenomenal and were a great gift to us. And I encourage others to hear that message and to invite people to your faculty.
Yeah, and we need to kick some of the accreditation people to have them recognize that we need people in different disciplines. I teach the big course on health policy at the university and get large numbers at the undergraduate level and get large numbers of nursing students who are mixed with the pre-meds, with the business students. I think I have a courtesy appointment in nursing. I'm sure I do. I'm sure Nana Parigala was smart enough to do that. And it's just important to get people from different disciplines. If you look at schools of education, they have long recognized that they needed political scientists, economists, anthropologists, sociologists. They have drawn from the disciplines. When I was at Teachers College, my first entry into nursing, I chaired a bunch of PhDs at TC who wanted to do PhDs at Columbia, and they did them on the politics of nursing. In fact, one of them actually wrote about the politics of this organization. And so they picked a discipline along with their fields, all the nursing things, nursing education that they had to do. And I think it's just important to broaden all of that. Thank you very much. It's been a pleasure. That was fun.
Isn't that wonderful? Isn't that wonderful? Thank you, Donna. Thank you, thank you. Thank you. We so appreciate your extraordinary leadership, scholarship, and all that you are, that you bring to tonight and this vision that helps us understand our present context. And your presentation was wonderful. Thank you. And in honor of your accomplishments, it is my great pleasure to bestow upon you, with heartfelt thanks from a grateful nursing education community, the NLN President's Award for National Leadership and Public Service. You would do us an honor by accepting. Thank you very much. Now, you may want it out. It is beautiful.
Thanks very much.
Thank you.
Wow, what a presentation. You know, you can't listen to Donna Shalala without getting a lesson in public policy and history, in our own profession. It was quite an experience, and I thought the questions were superb. So colleagues, let's give ourselves a round of applause for that interaction. I've come to a point in my age, which is progressing every year, I've noticed, that every now and then I make a mistake. I used to be perfect, but somewhere I lost it along the way. And so to my colleagues that I have made this era, it was an era of the mind and not the heart. The era was that the president of our beloved National Student Nurses Association is Joe Twitchell. And so, Joe, if you would please stand so we can appropriately recognize you.
Where are you, Joe? You're here.
And while I was apologizing, Joe, I thought I'd just as well recognize all the students that are here, regardless of what level or program you're in. All students, please stand so we can recognize you. Well, now it's time to switch gears from the splendid to the practical. Please bear with us as we quickly get through a few housekeeping details and logistics taken care of and point out some features coming up in the next few days. We're pleased to report that the 2011 summit is lighter and greener. I know you must have noticed. You notice that your tote bags are lighter. They're not as heavy as in previous years. In them, you will still find the Summit Program Book and the Guide to Exhibits, along with some information from our Star and Platinum sponsors. And of course, the ever-popular, handy Summit Pocket Guide is inserted in your badge holder. So you may ask, where are all the other important materials we once found in the bags? How can we find out about those important CEUs? What about all the NLN programming information coming up this year? Never fear. It's all here in the summit. All NLN-related information is now available in 2 places, at the NLN booth in the exhibit hall and at our new NLN information station across from registration. Information about receiving your CEUs is included in the white envelope you received at registration. And we also, just in case you can't find your white envelope, it's on a poster near registration. We have updated the process to make it easier and quicker. By October 1, you will receive an email containing a link to an online evaluation. Once you complete the evaluation, you will be guided to a certificate. As you know, there are many lunchtime activities during the summit. I think this is something we're going to say more than one time. Please remember to pick up your box lunches in the exhibit hall prior to going to any of these events unless otherwise specified. People are not into sharing their lunches, so you gotta pick up your own. Please don't miss our book signing this year. We are unveiling Global Service Learning and Nursing, edited by our own Joyce Fitzpatrick and Tamara McKinnon. Check your pocket program guide for the schedule. Tickets for the NLN Foundation fundraisers, Blue Man Group, and Arabian Nights will be available for pickup or purchase Thursday and Friday at the on-site registration counter, which will be open from 7 a.m. to 5 p.m. We really want to encourage you to pick up those tickets. Jessica Dixon is the staff face of our NLN Foundation for Nursing Education. She will have any information about that. Jessica, could you please stand so they'll know who you are? Jessica?
She's back there with the green.
She's back there, I'm told, with the green. She's waving her hand. She's near the door. She's trying to escape before you guys get to her. But no, not really. She's very serious about being available to you, and she's a wonderful person. And thanks to each of you who donated through this fundraiser. We really do appreciate your donations. A welcome reception and the grand opening of the exhibit hall are next. I forgot to mention I'm Beverly Malone, the CEO for the NLN. I thought it was about time I introduced myself to you. We hope to see you at the NLN booth. It's easy to find at the front of the exhibit hall, and we all, from the Board of Governors to the staff, look forward to visiting with you.
And now, though I hesitate to use the word highlights, because so many summit activities can be considered as such, here it goes. On Thursday morning, a panel of healthcare strategists who currently lead innovative programs to model the healthcare system in ways called for in the IOM report will present the role of nursing in realizing a transformed healthcare system, emerging models. The CEO Summit Address, Centers of Excellence and Research Award presentations, and the National Faculty Meeting take place on Friday morning. And I'm looking forward to closing the meeting with a few words about my tenure as president and president-elect of the NLN.
On Saturday morning, it's a long way away. The Laerdal Medical-funded Deborah Spunt Lecture, Leadership in Simulation, Looking Back, Looking Forward, celebrates its 5th year with a panel presentation featuring the leaders who have already achieved much success in this burgeoning field. Saturday is also the occasion of the NLN's annual business meeting, including Dr. Judith Halstead's inaugural address as the incoming president of the NLN. A favorite event, the NLN Town Meeting, follows with its open dialogue and discussion. And of course, please don't miss our grand finale on Saturday night with the President's reception and the annual celebratory banquet featuring the NLN Awards and the induction ceremony of the 2011 Academy of Nursing Education Fellows.
And before we close, there's a special person that we want to come to the stage so that we can recognize her on the occasion of her retirement. The epitome of leadership and volunteerism, a stellar educator, and an invaluable and irreplaceable contributor to the work of NLN, not to mention a very funny woman, NLN past president Dr. Eileen Zungalo.
Go ahead. She's
Dean
coming.
and Professor of Nursing at Duquesne University in Pittsburgh, Pennsylvania since 2002. Eileen has worked in higher education and nursing for more than 30 years. And though time does not allow us to list all of her accomplishments, here are some of those highlights. The establishment of the first and still only master's program in nursing in the state of Idaho. The creation of a seamless path for graduate study of the University of Illinois in Chicago, and the initiation of one of the nation's first comprehensive community-based curriculum in collaboration with the community of Boston. Eileen is a fellow of both the American Academy of Nursing and the NLN Academy of Nursing Education. She was a member of the NLN Advisory Committee for the Joint Commission for Accrediting of Healthcare Organizations and chaired the NLN Certification Commission, which oversees our academic nurse educator certification program. By the way, Eileen was one of the first to add the initials of INEF as a credential to her name. The recipient of many awards, Eileen is perhaps the most proud of the one for which the students of her students nominated her the 2005 Leader of Leaders Award at the National Student Nurses Association. And only Eileen could have managed all of these events and honors and to walk her down the aisle and onto the stage. And I could go on and on. For Eileen's work with NLN, I offer this honor. It's on the occasion, Eileen, of your retirement, and on it says, the epitome of leadership, a stellar educator, and an invaluable contributor to the work of NLN. Congratulations.
So very much. I realize that you're all excited to get to the exhibit, so I won't tell you any jokes now because I know you're in a hurry. Thank you so much. It's always such an honor to be involved in things with the NLN.
Thank you, Eileen. Thank you all for coming to the Summit 2011. Please take a few minutes to watch the Welcome to Orlando presentation, and then it's on to the welcoming reception exhibits and our posters. Be sure to see all of them. Welcome, and we're so glad you're here.